My review of findings on cerebral venous thrombosis, CVT, following COVID-19. Vaccination, Part 2. Introduction. I discovered that Shasavarinia and colleagues examined how COVID-19, caused by SARS-CoV-2, leads to multi-organ issues including neurological complications like CVT. They found that vaccines are vital for controlling the pandemic, but rare side effects, such as vaccine-induced immune thrombotic thrombocytopenia, VITT, and CVT, emerged. They noted CVT is a stroke type from clots in cerebral veins or sinuses, with an annual incidence of 1.32 per 100,000 in Western Europe. It affects women and developing countries more, with symptoms ranging from headaches to coma. Risk factors include oral contraceptives, pregnancy, and thrombophilic disorders, though 13% of cases lack clear triggers. Recovery happens in 80% of patients, with mortality under 5%. Materials and methods. I learned they used Joanna Briggs Institute, JBI guidelines, focusing on systematic reviews without meta-analyses due to limited data. They searched databases like PubMed and Embase until March 1, 2022, without population or language limits. From 886 titles, they screened 640 after removing duplicates, assessed 48 full texts, and included 12 reviews. 2 reviewers extracted data using JBI forms, resolving disputes by consensus. They evaluated quality with JBI tools, excluding studies with fewer than 5 yes responses. Results. I checked their results and saw that all 12 reviews met the JBI quality standards. AstraZeneca and Johnson & Johnson vaccines were most often linked to CVT, while Pfizer and Moderna had hardly any cases. CVT appeared 4 to 28 days after the vaccine, usually 7 to 11 days, with headaches as the main symptom. Most cases were in women under 45, with death rates from 28% to 44%, rising if there was brain bleeding. They found low platelet counts, high D-dimer levels, and positive anti-PF4 antibodies, which signaled VITT. AstraZeneca had 38.5% to 68.1% CVT cases, with deaths up to 83.3%. Johnson & Johnson had up to 87.5% CVT cases, primarily in women, and 61% died with brain bleeding. Pfizer and Moderna showed almost no CVT. Early treatment with certain blood thinners, or IVIG, lowered death rates. Being female, young, or using birth control pills raised the risk. Discussion. They confirmed CVT is rare, but more common with vector-based vaccines, aligning with CDC reports. They linked VITT to PF4 antibodies and platelet activation, similar to heparin-induced thrombocytopenia, HIT, causing clots and low platelets. They noted higher CVT rates in women, possibly due to vaccination patterns or biology. CVT risk was greater with COVID-19 infection than with mRNA vaccines. Headaches, the main symptom, can mimic other issues, but MRI and lab tests, D-dimer PF4 antibodies, aided diagnosis. They found that early treatment led to recovery. Conclusion. They concluded vaccination benefits outweigh CVT risks, though cases peak in younger women with vector-based vaccines. High mortality highlights the need for early diagnosis and management. Strengths and limitations. They valued the synthesis of 12 reviews for a solid evidence base and JBI rigor. However, no meta-analyses limited quantification, and study design variability caused heterogeneity. mRNA vaccine data were sparse due to fewer cases. Recommendations. They suggest clinicians monitor for CVT symptoms, like persistent headaches, within 28 days post-vaccination, especially in young women with vector-based vaccines. More research is needed on VITT and treatments, so this is just the start of my review. Let me know what you think. Please like and subscribe to learn more.